So good evening, everybody. We have evening here and hope you will have quite nice daytime Congress a couple of days ahead of us now. And I would like to thank everybody who really suggested to have this topic for the Congress on obstetrics and gynecology in Ukraine. So my topic today is related to coagulopathy biomarkers and solutions based on those biomarkers connected with the viscoelastic evaluation of the patient, which is based on ultrasound, sonorheometry. All this is going to be used to identify transfusion strategy in situations which are related to DIC syndrome-induced obstetric bleeding. So before we start discussing entire subject, I would like to bring your attention to the overall balance principle, how hemostasis is working. We have usually balance which does not allow to develop neither bleeding nor thrombosis. But then under some circumstances, we can have deficiency of coagulation processes, coagulation activity, which leads to the reduction of the factor activity and bleeding risk up to entire bleeding. On the other hand, when we have coagulation, which is working, looks like normally, we always have overproduction of coagulation material of the clot, and then we have to go through fibrinolysis to the disappearance of the excess of coagulation clot, and this sometimes goes wrong way and leads to production of the thrombotic materials, of the pre-thrombotic substances like fibrin monomers, like post-thrombotic substances, like thrombotic cement, which is based on high specificity dimer interactions, and thrombosis. What we have in our arsenal, to control and to manage those two parts, coagulation and fibrinolysis, disorders in coagulation is the bleeding risk and bleeding itself. Disorders in the fibrinolysis, we have thrombotic risk and thrombosis itself. So we have markers. For coagulation activity, we have factor activity markers like APTT, PT, which is modern version of PT we use here, and hopefully you also will get this experience, which comes from Scandinavia, Japan, Benelux countries. It's modified quick PT to Ovren PT, which is specifically good for evaluation of liver function and also factor 7 activity, and fibrinogen. And then we have thrombotic biomarkers, which is pre-thrombotic, like fibrin monomers and high specificity D-dimers, post-thrombotic biomarkers. All this is balanced by the natural inhibitors, antithrombin 3, protein CS, and lack of the activity of those is causing like so-called thrombophilic situation and thrombophilia, which is sometimes dramatically reducing clinical outcome in patients with DIC syndrome. So DIC syndrome, what we have in diagnostic and biomarker control there? First of all, I would like to draw your attention to the fact that DIC has two branches. One branch is hyperfibrinolytic DIC, and when we have consumption of all factors due to very active hyperfibrinolysis, so always thrombotic activity first, then it's so active that consumes factor stock, and you get consumption syndrome with bleeding, massive bleeding, and then you have to manage all this. And then we have not a hyperfibrinolytic DIC, which is for me even more dangerous and I would say more complicated because it goes through thrombotic arrest of small vessels, capillary network, blocking parenchyma of liver, kidneys, lungs, and it comes slowly. You may not notice that. And suddenly it goes to multi-organ failure. What we have usually in those different forms of DIC, the beginning always is pretty adaptive. The hemostasis tries to adapt, and usually we don't have this arrest, this damage. Then we have not hyperfibrinolytic or thrombotic DIC, which is followed sometimes with multiple organ failure. And there you have growth of fibrin monomers, D-dimers, without consumption of coagulation factors. And then you have hyperfibrinolytic DIC, where you have, along with thrombotic arrest, along with growth of fibrin monomers and high specificity D-dimers, we have consumption of coagulation factors, and then we have bleeding, which we have to manage. Treatment strategies, which are below with arrows, are different in every type and form, and we have to decide what to do, what kind of transfusion and treatment strategy to apply. For this, we have clearly understand, do we have thrombotic DIC or do we have hyperfibrinolytic DIC? So first, always there is systemic intravascular coagulation thrombosis. So this is always the start, and then it may go with thrombotic arrest only and multi-organ failure, and sometimes along to that with consumption syndrome and massive bleeding on top. So in both situations, we have scenarios. So when we have, thrombotic version, thrombotic DIC, you see a lot of fibrin coming up, and then you have thrombosis, and then you have multi-organ failure. And if we have hyperfibrinolytic DIC, we have consumption of coagulation factors, and we have bleeding, but final outcome in both cases might be, unfortunately, the same. How we diagnose that, how we see it early enough without waiting before multi-organ failure comes or before massive bleeding comes. So we have markers, laboratory markers of monomers, fibrin, monomers, high specificity dimer, high, because we have to have only the dimers which participate in thrombosis. And test should be high specificity, not to bring false positive D-dimer testing results, which is really a stress to clinicians. And then we have factor assays, APT, fibrinogen, overall PT, as I mentioned, platelet count, which bring us to the evaluation if there is consumption syndrome. If we have two groups of these tests, and at least if there is one from each group positive, that means reduction of factors or growth, active growth of thrombotic markers, the dimers or fibrin monomers, it brings us to the conclusion that we have DIC. Doesn't matter that we don't have massive bleeding yet. Doesn't matter that we don't have multi-organ failure yet, but we have it biochemically already, like DIC situation. This is clearly described in ISTH algorithm for DIC diagnosis and management, and it is based also on scoring. When we have these tests done and we give scores, and if we have more than 5 scores, so we have DIC. If we don't have 5 scores, we repeat it after 1-2 days, this testing. If we have less than 5, we don't have DIC. If we have more than 5, we have DIC syndrome diagnosis. So it helps to, stratify patients for DIC syndrome management. Why fibrin monomers are very helpful in DIC business? Because they have shorter half-life compared to D-dimer. It's pre-thrombotic marker, shows thrombotic activation. And then we have post-thrombotic thromboproduction marker, high specificity D-dimer, and this allows us to use both of those tests to control thrombotic activation within DIC context. Pre-thrombotic, post-thrombotic. Both tests helps us to have clinical management of the patient, also to have a prognosis of bad outcome. We have also good prognosis of the outcome as such. And if there is fibrin monomers are dynamically higher than the dimer, it is bad. It's really bad sign, because thrombotic activation higher than it's very high, and prognosis usually is worse. So testing both fibrin monomers and high specificity dimers is critically important for DIC scoring, and thresholds are given here on this slide, as you see. So we have situation when we have, laboratory biomarker monitoring of DIC patient, keeping in mind that our aim is not to jump into multi-organ failure, but to diagnose DIC without this bad impact, and without jumping into massive bleeding. However, in some cases, unfortunately, as the Italians say, we have massive bleeding, and we have to understand if we have DIC, or we have just trivial massive bleeding, or we have something different based on heparinization, and then we have already to use something extra on top laboratory control. The modern approach of viscoelastometric evaluation, which is internationally approved method to have point-of-care hemostasis control in massive bleeding, yes, it's sonorheometry. I'll describe what is it. First of all, viscoelastometry is really, everywhere cited, like a must method to manage transfusion strategies. First, in order to reduce transfusions, because it's not really good idea to have transfusion in general, but we have to do it when we have. On the other hand, to choose the right strategy, to understand which component to transfuse. This is the idea of viscoelastometry. And traditional viscoelastometric control like ROTEM or TEG allow us to do this. And there are training, I am training ROTEM for more than 20 years. It's classical methods how to manage massive bleeding situations. Yes, however, London study on the right, you see, of multi-trauma study, we have a lot of DIC situations. There are only less than 30% of clinicians able to use ROTEM or TEG when it's needed, because training and practice requires all the time, training sessions, teaching sessions, because you have to evaluate quite much by yourself, by your eyes. For example, there is ROTEM, you have situation of CT, MCF, XTEM, and UPTEM to decide if patient has DIC. Yes, in this case it has, but you have to have a comparison evaluation by your own, manually by your eyes. Then you have also take into account INTEM and FIPTEM, and then you know what to do. So it's not, in fact, that simple, but it is possible, and a lot of clinics are using this. Then you can have more complex views, and you need more practice, more experience to decide about what to transfuse first. And this actually possible again, but you have to be really experienced and to use algorithm, which is published, there are manuals of those algorithms, but they are not they are not that simple, and you have to be training periodically not to forget how to operate it when you need it. So what we can have here, like a development with application of sonorheometry and artificial intellect. So we have solution which allows for clinician to have training in 30 minutes. Why? Because you have results on display in green color or yellow triangle, yellow color, which says exactly if the component working or not. CSL is fibrinolysis, clot stability to lysis. On green, you have no DIC. On yellow, you have DIC. CTCS are factors. On green, factors are okay. If it's on yellow, deficiency. PCS is platelets. On green, platelets are okay. On yellow, deficiency. So you have to transfuse. FCS is fibrinogen. On green, as you see, white triangle, it's okay. If it's on yellow triangle, it's bad. You need also fibrinogen. So all this evaluation becomes damn simple, and I think this is huge help for clinical practice. So let's go further on to be on time. There is example of yellow. CTCS, you need factors. You see it's on yellow. PCS, platelets, you need platelets. FCS, it's on yellow, you need fibrinogen. CSL, it's on yellow, you have tranexamic acid as first because it's DIC situation. So that's it. No curves, no sausages, nothing that you have to practice, not to forget, and then you can move forward. So this is exactly how you make this simple interpretation. So, manuals also are prepared. And for example, when you have patient which is after surgery, is bleeding, you have to decide if this is hemostasis or if it's surgical reason. If it's on green, all components are working properly, hemostatic components. It means it's surgery. So you go for revision. If it's on yellow, it means first you transfuse, correct hemostasis, then you decide if you go on surgery or bleeding stops and all is fine. So, for example, DIC. Again, on yellow, CSL, it means that it is DIC. If it's on green, no DIC. Let's say platelets. On yellow, it's platelets. Yes, so if it's on green, platelets are okay. So it's specifically a dial which shows exactly which component you are discussing, and if you need, says if you need to transfuse this component for the patient. So you can have also even a hypercoagulation situation with some, small practice as well. But this is auxiliary, I would say, auxiliary value of sonorheometry. So in the end, you always may ask yourself how trustful it is, how internationally approved this system is. And I have to say that it's just the recent news why I wished to share it with you, that the most serious, most, valuable clinical confirmation of safety and effectiveness of clinical solution is FDA approval. So exactly for obstetric bleeding management, sonorheometry was approved as a very safe and effective method by FDA, 510K grant. This is, I would say, the only cartridge-based point of care hemostasis control which has FDA approval for this specific clinical situation when you have massive obstetric bleeding. So this was also announced officially on all kinds of websites, and it is also based on peer-reviewed clinical trials, which, proved the ground for this FDA validation. So I would say this is the modern experience and modern way of control bleedings in obstetrics context for every clinician, even not clinician, even nurse can see which component to transfuse. So this may also, in some situations, you can see there are some studies in cardiac surgery where you have reduction of transfusions, dramatic reduction of transfusions, and this is also very important, value of modern point of care sonorheometry control. Yes, so at this point, I would like to thank you for your attention and wish excellent Congress when you have it. So all the best. До зустрічі.